My name is Malachy Clancy. I am the occupational therapy team leader for Good Shepherd Penn Partners. I primarily work at the Hospital University of Pennsylvania here in Philadelphia, PA. So my current role is kind of the same as it has been. So as the occupational therapy team leader, basically what my role is throughout our organization is to provide direct patient care. So that's probably like 75 to 80% of my job. And then the other 20-ish% is staff education, mentoring, program development, kind of like clinical leadership. So our job is primarily trying to just provide clinical education to staff throughout our health system. So typical week, again, primarily my primary patient care role is I'm the primary OT for our heart and vascular intensive care unit. So a normal week for me pre-COVID was primarily providing evaluation and interventions in our heart and vascular ICU. And then, there would normally be meetings associated with my clinical role, which have adapted a little bit more. And now kind of what my new role has shifted to is I am one of the primary OTs for our COVID ICU and our COVID ward service. And most of the meetings that I'm kind of primarily involved in now is assisting in developing a rehab plan and interventions and training for our staff for the COVID patient population. So it honestly, it hasn't changed drastically. We're still treating patients. We're still providing clinical interventions. I would say that it's just shifted primarily to focus on the COVID patient population over the last few weeks. Now that things, I want to say, have stabilized a little bit, we're starting to try to get back into, projects and things that we had planned pre-COVID. But primarily right now, I am the primary therapist for our ICU, our COVID ICUs, which we have 3 of at our institution right now. And really what the focus has been is supporting our staff, not only OTs, but PTs and SLPs, on ensuring that they feel comfortable and have the tools and resources that they need to provide intervention and rehabilitation for these patients. So right now, I would say we're even doing like 1, 2, and 3, and we're trying to figure out now, there's talk about telehealth for stage 4. So the patients that are home, how can we continue to provide appropriate rehab services to them in their home environment? But yeah, we're seeing patients, we're seeing them both in the ICU, they're kind of theoretically 2 points of entry. You're either coming in through the ICU or coming in through, the ER and going to the floor. We're seeing patients in both. And we're seeing, I think the great thing that we're seeing now, we're seeing patients survive, which is great. We've seen patients leave the ICU, we've seen patients go to the floor, and we've seen them go home. And with the cohort of therapists that we have, we're able to provide continued coverage between both the ICUs and floor services. So we're seeing functional progress, which is great. So when all this started, we asked therapists if they'd be willing to volunteer. We've got a great response. We have a dedicated group of OTs, PTs, and speech therapists who have volunteered to treat these patient populations. We didn't mandate it for anyone. We told everyone at any point if they wanted a break or wanted off the team, there would be no questions asked, and they could do that at any time. So with the staffing that we currently have, we're able to manage the caseload that we currently have, and we haven't had. I think staff feel supported. The best, we've had a lot of just, we've opened up the door where we've said, if you have any questions, just come talk to us. There's a lot of unknowns. We've said, we're not going to have the answers to everything, but we'll try to get you the answers to what we can. And I think even we've taken people to see the units and see the floors and show them the environment, and visually seeing things is is a lot more calming than just, talking about it as well. So I think the staff members have felt a lot more comfortable in doing that as well. From a large health system, we had a lot of clinical resources and videos that are available regarding like the disease process that we reviewed with our clinical staff. We looked at the different resources from both AOTA and APTA. I know I've looked at like a lot of the different research on the OT community. We talked a lot with our clinical colleagues in both nursing and critical care, primarily regarding like the timing of intervention. When do we think is the best time to approach and provide intervention? We didn't want to necessarily go in too soon and make the medical status of the patient worse, but appropriately identify when we thought we would have the most realistic and feasible outcomes. In regards to that, the only other thing that we've done differently, I think, we've just taken the process a lot slower and just had a lot more dialogue and conversations with people to make sure that they felt comfortable. I think that the staging of the disease process and AOTA's webinar that they did on the pandemic, I forget what the official title of it was definitely helpful. I think that what we did at our institution to expand on that is like, look at now, okay, so what is the service delivery of that model is going to look like? And we have shifted a little bit to provide actually increased frequency of care for some of these patients to expedite their rehabilitation process and their discharge from the hospital setting. Actually, it's so we've considered longer sessions BID if necessary.
Okay, sounds good.
Yeah, and particularly thinking of like, I've done more FaceTiming and family training over the phone than I have ever done probably in my entire career. And thinking about like, what are the, what equipment might an individual need? What resources might they need in order to get home? And so, I don't think it's much different than like her traditional ARDS patient population. So the big thing that we're seeing is profound critical illness and deconditioning and profound amounts of delirium. Like the patients that we're seeing are grossly aware of themselves, but have no real insight or understanding of what has happened to them over the last 18 to 20 days. And that's being exacerbated by the fact that they've been sedated so long, they're not used to, or they're not receiving as much physical intervention or stimulus throughout the day. They're not getting, up and out of bed as much as they normally would have if it was a traditional ICU patient or anything else. So with that being said, I think the other aspect of it is, we're not able to provide as much of normal equipment that we should have based upon like the risk of contamination of bringing in large pieces of equipment into a room and then moving them around to different units and everything else. With that being said, it's not much different per se than the traditional ICU patient on focusing on like increasing their arousal, increasing their activity tolerance, engaging in basic ADLs, starting to get them over to, a sense of a structured normal routine throughout the day. I think the big shift that we're seeing closer to discharge is more of the family training process. So ensuring that the family and wherever that person is going has a general understanding of how to safely take care of that individual so that they feel comfortable in the home environment. We do have patients going to post-acute levels of care. I will say that each individual institution has their own requirements on what that looks like. I think that our social workers have done an excellent job of helping us to facilitate like what clinical settings are taking patients. One of the most interesting things that we saw early on was that we are seeing large volumes of patients with end-stage renal disease who weren't able to leave yet because of outpatient HD sites. They weren't accepting COVID positive patients just yet. We've had a large number of patients go home with that being said, and we've had we're starting to see a larger number of patients who have tested negative and are now able to go to post-acute sites as well. So it's been variable. Other thing that we've started to see now too, initially, we're probably like, I want to say 8 to 10 weeks into this. We saw large populations of individuals coming in together. So we'd see like there'd be 3 or 4 family members all spread out on multiple different floors. We saw individual neighborhoods or towns like with large incidents of cases coming in together. It started to level off a little bit, but we've also seen, you know, this virus does not discriminate. I've treated anybody from 20 to 95 years old. And we're seeing a lot of, along with the neuromuscular side of things, we're starting to see strokes in a certain subset of the population. We're seeing patients who we thought were clinically stable wind up getting reintubated and back into the ICU. It's extremely tough to differentiate like where they're at in their disease process for certain things. You know, we've seen people who are extubated in the morning, reintubated 2 hours later, who we thought were appropriate and fine. I think that with all that being said, for the patients who are stable enough to get home, patients who we've traditionally, you know, would strongly recommend for post-acute levels of care, their families don't necessarily feel comfortable sending them either as well, because they're afraid that, you know, as you start to see in larger like nursing home populations and everything else, that where the virus is being exacerbated, that they'll either get it again or not get the care that they need. So we're sending, as crazy as it sounds, you know, patients who are like max assistive 2 home to their family members and trying to provide family training over the phone. So I think it depends on what population you're in. So for example, I know the International Society for Heart and Lung Transplantation has put out some different resources on particularly like the heart and lung transplant population. We've actually seen some patients who have left ventricular assist devices test positive for COVID-19, which is unique and interesting aspect. And one of the other things that we've kind of looked at is the Society for Critical Care Medicine has some guidance documentation out that we've also reviewed. The only other thing is, like, you know, we come from we have the resources of a large health institution from the University of Pennsylvania, and we were really beneficial to have all their different resources. And we've talked to a lot of the different critical care pulmonologists and medical ICU attendings who've provided us a lot of different knowledge on, you know, the disease process. I think everyone's kind of learning together, which is beneficial in a sense. You know, it's interesting, you know, not one person is, I would say, considering themselves an expert in this. You know, everyone's kind of sharing what they know together. You know, probably like a lot of my colleagues and I have all said this. It is amazing to see like the different aspects of partnership that have emerged from this. You know, I think that everyone worked really well together to begin with, but now that this has kind of put such a large burden on everyone across the different health system, that it is really amazing to see like all the different positive things that have come out of this. Call it the MOVE criteria. So if you look at the first letter in each one, myocardial stability, oxygenation, vasopressors, engagement, simple 4-step process for thinking about an individual's clinical stability in the ICU, anywhere, basically, right? So you think the first step is the patient's myocardial stability, whether or not that their heart can demand the activity that you're asking of them. So you think about like a stable heart rate, a stable rhythm. Have they any EKG changes? Have they had any changes in their cardiac enzymes? Grossly, yes or no. You move to the next thing. You think about oxygenation. Generally, does the patient have an FiO2 need less than 60%. And again, that's on like a case-by-case basis. Yes, I have seen patients who have required an FiO2 greater than 60%, but thinking about like an 80-20 rule, again, we're kind of thinking of the patient who is grossly medically stable. The next step would be vasopressors, whether or not the patient has increasing vasopressor need. Generally, again, we're seeing patients who are on 2 vasopressors or less. And then the last step is the engagement aspect. So, is it appropriate? Is their level of arousal there? Are they following some commands? This is kind of the last step in the process, thinking about like, can you go in, can you engage the patient appropriately? I will say this might be the one thing that has kind of changed for us. So, in traditionally, like if you're working in like a neuro ICU, for example, and the patient's like a RAS of -4, you go in and you try to provide some intervention, sitting them up, providing some sort of sensory stimulation or to increase their arousal to see if there's a change in their behavior. We're not necessarily doing that as much right now. We're waiting to really see if the patient is showing some low level of arousal, so like a RAS of -2, a RAS of -1, then going in and providing a basic evaluation and moving forward from there. And this has been changing. We're starting to see moving away from it a little bit more and starting to see patients with lower levels of arousal. But to start, that's kind of what we worked off of. It has fluctuated a little bit. But I would say most of our patients fall into these general guidelines. And the one kind of thing along with this, there's probably some therapists who have seen patients on like high flow nasal cannula or oxygen. Yeah. So that is kind of the one thing that we've also been pausing on a little bit, because we're concerned about traditionally, if a patient was on high flow, most of the time that they're able to appropriately manage that on a ward setting, and they'll be able to wean back to a nasal cannula, or, if the patient starts to decompensate a little bit, move to BiPAP. With the clinical state of this virus, if there starts to be escalating O2 needs, the next step they're going to is intubation. So the guidance that we've got from our critical care colleagues is that anticipate a low pulmonary reserve with this patient population, primarily those who are on high flow, and limit the activity that you're doing with them. So for example, we're not going in, we're not doing more strenuous ADLs, like we're not doing standing tolerance for prolonged periods of time. We're not getting washed up standing at the sink or anything along those lines. It's kind of bed to chair, bed to commode, ensuring that they're managing their oxygen saturation okay, and really watching their work of breathing. We've done a lot of just clinical observations from outside the rooms or outside the windows of patients, just to kind of watch their breathing pattern before going in, making sure that they seem clinically appropriate, and making sure that, over the last 24 hours or so, that they haven't had increasing O2 needs. And patients who traditionally, if they were extubated in the morning, we might go and see them 2 hours later. Sometimes now we're giving them 6 to 8 hours to really ensure that they're medically stable and medically appropriate for therapy. I think that the biggest thing is like when this started to occur, we started planning pretty rapidly. So I think just starting to put a plan in place on like recruiting volunteers, thinking about like what the process might look like, who might be providing the interventions. We really looked for therapists with a background in like cardiopulmonary patient population, and asked if they would be willing again to be a part of this process. But I think just open communication and collaboration has probably been the best thing about this. Being open about your experiences, even if you don't know the answers to things, the questions that you're getting asked, has helped to kind of reduce nervousness and anxiety. You know, it's a scary thing. You know, I don't think there's anything differently that I've done. I think one big thing that we did operationally is we shifted our schedule around, which has helped. So, you know, traditionally we'd work 5 days a week with a, you know, weekend day in between there. We've moved to 4 10-hour days. So most staff members now work 2 days and have a day off, which I think has been great and kind of like allows a fresh reset. They've been, a lot of our operational leads have been great with asking people if they need time off. You know, just giving people the chance to step back and away from it as well.